Well, it's my pleasure to introduce Dr. Taneisha Wilson, who's the speaker today. Dr. Wilson is an assistant professor of emergency medicine at the Alpert Medical School of Brown University, where she leads research efforts to understand and combat the impact of racism on emergency department patient care and workforce experiences. Dr. Wilson received her medical degree from the University of Connecticut School of Medicine, and she completed her residency in emergency medicine at Rhode Island Hospital, as well as her fellowship in injury prevention at Rhode Island Hospital. During her fellowship, she earned a master's degree in clinical and translational research from the Brown University School of Public Health, and her current research focuses on the development and implementation of anti-racism programs in the emergency department and their impact on patient outcomes and workforce satisfaction. Dr. Wilson has been very dedicated to advancing equity and justice in healthcare through her research and teaching. And on a personal note, she is a wonderful colleague and friend. And so we're so happy to have her speak today. Dr. Wilson.
Oh, Dr. Zinfrillo, that was all too kind, as you know. Thank you so much for that wonderful introduction. Really, really pleased to be here today. I'm going to start sharing in 1 second. Make sure I'm sharing desktop too. Is that appropriate? Yes. Oh no, 1 second. I think I lost my sound for some reason. Ah, man, Julie, I thought we practiced this. Oh, Mark, you were on mute, maybe.
I was muted. I was muted. Sorry. We could see the your presentation mode. So
Okay.
I think if you do that and do swap displays, that might work. There you go.
There you go.
Yay! Yay! Okay, awesome. We practice and still, all right. Okay. I just try to leave our meeting also, which we don't want to do. So, all right, good afternoon, everyone. Thank you so much for being here. Today we'll be discussing advancing injury research through anti-racist practices. And this is an introduction to the levels of racism and the impact on health. So, Dr. Zinfrillo just introduced me. I'm Taneisha Wilson. I'm one of the faculty here. So I do have a few disclosures. A lot of this work that I've done in the past, and so most of this presentation actually was created with Dr. Hannah Barber Doucette, who was one of our pediatric emergency medicine fellows, is now at Boston Medical Center, living her best attending life and continuing her anti-racism work there. That's her and I, our Society of Academic Emergency Medicine meeting. I also want to disclose that most of my time is funded by SAEM, the research training grant, and also by the Brown Physicians Incorporated Minority Faculty Development Grant that provides funding for my research. And the final disclosure is that, just in case you didn't know, this is a part of a series. And today we're just focusing on an introduction of terms, and we'll follow up with a state of anti-racist injury research, so we can all see some great examples of what's happening out in the world and create our best practices here as a team. So, here we are today, and we're talking about anti-racism as a part of this initiative because we know that the delivery of healthcare is inequitable. There's really no question about that, especially amongst this group. I just took a quick look at the names, and I think we all are in agreement here. And we know that racism really, not race itself, but racism and race-based bias impacts how we live, where we work, where we play, where we go to school, where we seek healthcare, and it ultimately impacts our exposure to injury. And we must consider racism in our approach as providers and researchers, not only because it's a moral imperative, but simply because the state of our state is changing. In 2019, the CDC reported that amongst Rhode Islanders, 46% of Rhode Islanders who were between the ages of 0 to 4 were people of color, so non-white. So this is something that we have to really think about in our state. And today, specifically, we're going to be We're going to develop a comprehensive understanding of the historical and contemporary dynamics of race and racism and their impact on health specifically. We're going to examine some of the historical roots of institutional racism, both in science and medicine, and its impact on these marginalized communities. That's our focus. We're going to analyze the impact of different forms of racism, so individual, institutional / structural, and internalized on health outcomes. We're also going to develop the knowledge necessary to recognize and actively counteract racial bias in the healthcare setting and in our work, and develop a short action plan for addressing racism in healthcare and promoting health equity for our patients. Race, our definition of race today is race is a classification of human beings into groups based on physical traits, ancestry, and social relations, or the relations between those two things. We know it's a social construction. These social groupings were, they're made up demarcations that have changed over time, and we'll explore some of that as well. It's really a crude and really inaccurate proxy when we use race for socioeconomic status, culture, and genetics, right? We know we're not supposed to be using it as genetics. We know that it's a precise, while it's an imprecise measurement of any of the things we just mentioned, such as status or culture or genetics, we know that it's a very precise measurement of where people are socially classified in a very race-conscious society. That's where we live. And we know that racism is a system of structuring opportunity and assigning value based on a social interpretation of race. And these definitions I adapted from Dr. Kamara Jones, who's a leading physician advocate and public health researcher. And if you haven't been exposed to her work as an anti-racist researcher, I really highly recommend some of her work. So we know that racism really results when we use race as a basis for structure and opportunity and assigning value. Just to double down again, Dr. Dorothy Roberts, someone else who, if you haven't been exposed to, I really, really highly recommend exploring some of her work. According to Dr. Roberts, race is not a biological category that naturally produces health disparities because of any known genetic difference. Race is a social category that has staggering biologic consequences, but because of the impact of social inequality on people's health, not because of melanin content. And finally, just the last definition, I promise. An anti-racist really is a person who actively opposes racism. And I'm going to leave off the racial tolerance. Tolerance is just such a meek word, but it's someone who really actively opposes these tenets. And that's what we all aim to do here. So we know that over time, there have been many definitions and categorizations of race that have emerged, and some are influenced by science and medicine. All are influenced really by science and medicine, some by our cultural norms. But so all these categorizations have served to do really one main thing, really to perpetuate oppression, exploitation, and social inequality. We know this because by the 17th century, when slavery was legally established in the colonies, we had to come up with a way to base our notion of racial inferiority on something. And we went back to science. So Carl Linnaeus was a leading Swedish botanist. I think know Linnaeus in some way if you took high school biology, and over time developed the nomenclature, the taxonomy that we use for all organisms, and specifically he developed one for humans as well, because we are an organism. And he describes Europeans with multiple favorable attributes while describing Africans and Asiatics and Americans, which is indigenous folks, with unflattering natural tendencies based on the 4 humors. And I'll just give you a minute to read what those humors are, because I refuse personally to name them out loud. So, Dr. Samuel Martin was one of our most notorious racists back in kind of doubling down on the social inferiority of anyone non-white. And he used skull size and measurements as a proxy of intelligence, claiming that Caucasians have larger skulls and gave them superiority. And I just use the word Caucasian on purpose as a plant. I think of this word as an antiquated word, similarly to how we think about Oriental. And it's something that I'm working to remove from my vocabulary, because I think when we use these scientified terms, biologized terms to describe differences, that really kind of reifies the thing that we're trying not to do, which is establishing race as biology. So we will avoid using the term Caucasian. I will endeavor to do so myself. And we know that these policies, again, is not only against Black folks, but our indigenous peoples of the United States had some degree of race-based bias, and especially in thinking about who to allot land to during the provenance of the Dawes Act, right? You had to have some degree of Indian blood to be given anything. And we know that this has like perpetuated a lot of inequities in our native populations here. I think, William Ripley was one of the anthropologists who categorized actually white people into sub-races. And this was later used to justify having folks who are Irish, Italian, and of Eastern European descent, giving them kind of lower job statuses, right? So this affected not just people of color, but also white people who identify as white now. And that changing definition of what whiteness means, again, just goes to show like who gets to be white is now different than who was white in the 1800s. This continued in the early 1900s, and this has actually continued. We know that with a Tuskegee syphilis study that followed the natural history of syphilis in poor Black sharecroppers. While the participants were not purposely infected with syphilis, they were not told of their diagnoses during this like atrocious study. And I think most of us here who had some sort of history class have heard of this study. And once the public gained knowledge of this through journalism, it wasn't the researchers or the physicians or the nurses or the community health workers that were working in Alabama that kind of blew the whistle on this. It was a journalist. Once it became public knowledge, along with some other atrocious things that were happening in communities of color, this really helped ensure protections for all study participants. So our IRB with the Belmont Report and all that was kind of born out of the struggles of the folks from Tuskegee. And even moving onward, after World War II, and we as a world understood how detrimental it could be to assign race-based value because of World War II, UNESCO declared that race is not a scientific basis for anything, because we know that's a lot of what the Nazi regime based their discrimination and murder of Jewish people on, is that they were somehow different and flawed because of their Jewish race or ethnicity. And so as a world, we decided that, obviously we're going to, before we even sequence the Human Genome Project, sequence the human genome with the Human Genome Project, we as a society decided that we were not going to use race as biology. However, even in the early 90s, I know some of you probably remember this Oprah episode with Dr. Oz. It's one of his first episodes on Oprah. We were thinking about this salt hypothesis that the people that survived the Atlantic slave trade had to drink a lot of salt water, and that's why Black Americans had a higher propensity for having high blood pressure than white Americans. No one really mentioned the idea that actual racism in society was causing, and the stress of living in a race conscious and very race-based society was causing increases in blood pressure and cortisol. Like that wasn't really the paradigm that was used then, and this continued even in the 2000s, right? In 2005, the Bidol was approved by the FDA as a race-based drug. I believe that approval has since been rescinded, but it is something to that still continues today, is that we do think that there's somehow genetic differences between us as humans. And even moving from those scientific definitions, we know that our small state is not immune to racism, especially when you think about redlining. Just thinking about the geography of our city, where where the airport lies, where our plants lie, and just like a little bit of history. In 1831, a mob of rioters actually razed Snowtown, which was a black neighborhood up by Capitol Hill, and that's where our city hall resides. So I think, you know, it's even born home here that we're really not immune to the long lasting effects of racism in our society. And I'm just going to move on to describing to us our levels of racism. Uh, Dr. Jones, again, provides a framework for us to think about how all these levels of racism are really intrinsically interrelated, and they do have unique impacts on health, and we'll talk about why. So, institutional racism is really differential access to goods, services, and opportunities in a society based on race. And it is often normative. It's something that exists. We don't really think about it. It's sometimes legalized, and you'll hear the de jure, J-U-R-E, de jure, versus de facto racism. You know, de jure racism, things like Jim Crow laws that was codified into law. But because of, you know, the 50s, we still live in the United States. Now we have de facto racism, so those things aren't really codified, right? So these are really things that are kind of embedded in our government and institutions, and there often is no identifiable perpetrator, we like to think, but it really does manifest as and can be evident as inaction in the face of need, and we'll explore that too. So, you know, the material conditions we talked about, this manifestation is quality education, sound housing, gainful employment, you know, having appropriate medical facilities that aren't crumbling, having clean water and a safe environment, living in a place where you're not ingesting toxic fumes or, you know, being exposed to low levels of radiation, whatever that might be. And, you know, on the other hand, thinking about really important access to power, right? Um, who gets information, who creates information, who has resources such as, you know, generational wealth and organizational infrastructure, who has a voice, who gets to vote en bloc, whose voting rights aren't really being taken away, and who represents who in the government, and who has control of the media and representation of different folks. So in order for us to further describe this concept of institutional racism that Dr. Jones created, we're going to use her analogy of her garden. So I want us to consider two plant boxes. Yeah, you have your lovely one with rocky soil. I'm gonna start with the rocky soil here, and one with nice, lovely, fertile soil from the hardware store. So our blue box is our hardware store box. So we're going to use our hardware store-bought flower pot with its delicious, lovely, brown, sweet-smelling soil as our unearned privilege. And we have our gardener. So the gardener, she has 2 packets of seeds, right? They're the same variety, but they're very different colors. So one's red, one's pink. So we'll say that the historical insult in this case is that the gardener, she loves red flowers. She prefers them to pink flowers. So she's going to plant them in her delicious, nice, sweet smelling soil. That's where the red seeds belong. Unsurprisingly to all of us, the red flowers, they grow beautifully. They didn't do anything differently. They were just red, and the gardener liked them, so she put them in the nicer box, right? So we know that societal norms and can really persist, because at the end of the season, the flowers, they go to seed, and next spring they come back, but nothing's changed, right? We haven't really fertilized the pink flowers. We haven't fertilized the red flowers either, but their soil started at nice and stronger grade than our pink flowers. And, you know, the years go by, right? And the gardener's like, what the heck is happening? Why aren't the pink flowers growing? I mean, I'm doing the same things, but in reality, she hadn't really changed her soil. They haven't been rotated to touch the sun. As you can see here, her beautiful red flowers were always facing the sun. Like, there was no change in her approach and treatment to them. It's just the understanding that one pot was doing better than the other pot. Right. So because the gardener really failed to provide fertilizer, sunlight, she didn't move the pink flowers and change her pot, this perpetuated this kind of inequity, right? And at the end of the day, the gardener's thinking, well, I mean, it's not my fault. Like, I tried to do the same thing. I water them. Obviously, they should be fine. But their base was very different. Their foundation was different. So, in our context, who is the gardener? And who has the power to decide to act and to control resources? And we could argue that's government, media, corporations, foundations, and who's leading this, right? And it can be dangerous when the gardener is allied with one group, and as we saw here, that she loved her red flowers, and so she was really not concerned with the outcome of the pink flowers, because she was focused on the red flowers. And it can really, really be dangerous when the gardener is not aware of this kind of inequity, right? We also think about health disparities and with the outcomes of institutional racism. We know that poverty-related illnesses such as low birth weight, infant mortality, asthma, cancer, depression, things that affect us, the people who experience disparities have a greater risk of injury and suicide, especially among our indigenous peoples of the United States. And folks who are vulnerable often do make unhealthy food default decisions because they live in food deserts, right? So things for us to think about. We also think about access to quality healthcare. So folks who are vulnerable often have limited health literacy and education, and can have lower levels of coverage of health insurance, and really limited access to healthcare institutions, especially when we think about those vulnerable people live in far, distant neighborhoods. The bus doesn't really go there. People living around crumbling infrastructure. Folks living in rural areas actually do count, and those who are underfunded health systems. And we'll delve into one of those health systems now with our indigenous peoples of the United States. So in 2010, there were about 5.2 million American Indians in the United States, and 566 federally recognized tribes. But the poverty rate amongst our folks was about 28%, and that's twice the national rate, with 18% of these folks not having any health insurance, and only about 28% over the age of 5 speak a language other than English at home, which I think should change. So our major health disparities for indigenous folks too, when we think about specifically thinking about injury and having adjusted for age, we know that our indigenous peoples, especially in the United States, have higher rates for a majority of outcomes that we think about, things like alcoholism, injuries, suicide, homicide, things like that. The Indian Health Service, and again, this is thinking about providing those services as the appropriate gardener. While the IHS provides healthcare to about 50% of the Native population, the quality of care is really hampered by shortages in funding. And in 2013, because of sequestration, their budget was cut by 800 million. And already we know that this population has very disparate outcomes, and with a budget cut, which doesn't quite make sense, right? And while the IHS is, and it's like I should have explained, it's actually 3 branches of the IHS. There's a federally funded arm that when folks mention that they're going to work for the IHS, for like loan repayment, things like that, it's typically the federal arm that that's the mechanism under which they're going. There's also the independent and tribally operated system, and smaller urban healthcare programs like community centers, things like that. But while they do, get respond to Medicare quality measures, a lot of the IHS physicians, when surveyed, reported that they had very limited access to high quality specialists for their patients. They had limited access to high quality diagnostic imaging and outpatient mental health services, also non-emergent hospital admissions. And they cited, these physicians who were responding cited a lack of really geography, but primarily a lack of funding to the IHS as a barrier to providing specialty care for their patients. So this should not be, an inverse relationship, right? Rather, if you have more need, you should get more healthcare. It shouldn't be you have more need and you get fewer services. That shouldn't be the case. Um, but as evidence has shown, that is actually how healthcare is delivered to a lot of our vulnerable folks, and um, who have been marginalized, really, as we discussed, because of racism. So another study that we wanted to highlight that kind of brings to home the idea of how racism impacts, especially that institutional type of racism, or what we think about institutions impacting health. Um, in 2018, Bohr and colleagues looked at police killings and their spillover effects on the mental health of Black Americans. And this was a quasi-based experimental population study. So they used a 2013-2015 CDC BRFSS survey that looked at, combined that survey data about mental health days with national police killing data. And I'd have to defer to Mark Ardale Steele about this, or Steele about this, but very fancy statistics. And so they enrolled about 38,000 of the 100,000 Black American respondents that reported that were exposed to more than one police killing of an unarmed Black American in their state in the prior 3 months. So for each additional police killing of an unarmed Black person, there was an associated 0.14 additional poor mental health day during that time period that the respondents responded, right? And they noted no impact on white American respondents, and this was significant. So at the outset, these authors postulate that the police killings of unarmed Black men, not armed. They actually ask questions about armed police killings, but it's specifically unarmed, could contribute to 1.7 additional poor mental health days per person per year, leading to 55 million excess poor mental health days per year among Black individuals. And this is even comparing the effect of mental health days amongst people with diabetes. So that for them, I think it's 1 they found that there was like 75 million poor mental health days among Black Americans. This was their control ask, compared to 55 million. So, some would argue that the effects are very similar or really profound when you think about just hearing a report of an unarmed killing. So, moving on. So why do we spend so much time on institutional racism? It's because institution and policies can be frequently internalized as real. Police killings of unarmed Black men. Okay, that happens. Like that, there must be a reason for that, right? There must be a reason why there are poor outcomes among or indigenous peoples of the United States. Not considering the fact that there was underfunding, there's all this unconscious bias. So while we are internalizing all these things, how are we kind of exploring them, or experiencing them between individuals? And this brings us to personally mediated racism, which, think about as prejudice, really. And we're going to just name it what it is. There are folks folks out there might be among them that, there's prejudice, there is bias, there is microaggression, and sure, we can argue semantics, whether or not it's stage 1 racism, stage 1.5, stage 4, stage 3. Right now, we're just going to call it all that. I think in our next iteration, we'll talk about thinking about grading our areas of racism and incorporating them into our research if we decide to do that as a group. But here, I just use racism as a broad term when I mean bias, microaggression, whatever it is, it's race-based differences. But just moving on. So prejudice is a differential assumption about the abilities and motives and intentions of others according to their race. Think about discrimination, which is differential action according to someone's race. And while these acts of racism may be, implicit, explicit, intentional, unintentional, and can be acts of commission as well as omission, what we do know is that they can manifest as lack of respect, suspicion, devaluation, scapegoating, dehumanization, again, treating people differentially, right? And while personally mediated racism, it really can be overt. It really is most often unintentional, right? And based on all these unconscious biases that we've been fed, um, really over the last 400 or so years. And all our actions really can be influenced by these. And this can lead to disparities as well. So the institution, person, right? So it really, again, the cogs are all connected. So we know that minority Americans are really less likely than our white Americans to get many effective and surgical services across a variety of settings. I think in this group alone, we've talked about pain, treating pain for injury, lower rates of revascularization, and fewer prescriptions for beta blockers after you've suffered an MI. There was less timely administration of antibiotics for pneumonia, more sepsis, more worse outcomes, more worse. That there are less optimal. There's less optimal care for diabetes and fewer prescription for inhalers with children with asthma, fewer cancer screening tests, among others. And while we pull that from a 2003 article, that it goes on, right? And it's not only myriad of examples, especially in injury. So patients who have actually experience or report experiencing or perceive that they have experienced discrimination reported poor health outcomes for things like hypertension and sleep quality in Black Americans, lower uptake of any diabetic services in Indigenous American women, and increased frailty in Asian American, Pacific Islander, and Latinx/Hispanic elderly folks, and increased sexual risk behaviors in men who have sex with men, especially those who are Asian, African American, or Latino, and increased risk of preterm birth in African American women. These are people reporting that they, perceive discrimination. So it exists with our patients as well. So in this context, considering the historical examples like the Tuskegee syphilis study and the ongoing discrimination that we know that folks experience both in and outside of the healthcare system, it's unsurprising that many Black Americans harbor a really deep distrust of the healthcare institutions and of clinical research, right? And this mistrust was highlighted in this one article by Corby Smith and colleagues, and it showed that African Americans specifically were more likely to believe that physicians prescribe medications as a way of experimenting on people without their consent, and that they themselves believed that they had been subjected to these experiments. Right. So how often, if ever, do you think physicians prescribe medications as a way of experimenting on people? And 62.8% of those who identify as Black said very often, fairly often, while only 38.4% of those who identify as white said responded the same. Similarly, in your thinking about those who believe that someone has ever experimented on them, and that has really grave implications for us and our work. So, internalized racism does affect how our patients really see themselves, right? And our colleagues might see themselves. So this is, acceptance by members of any stigmatized race of any negative messages about their own abilities and intrinsic worth, and can manifest as self-devaluation, resignation, helplessness, hopelessness, stereotype, threat, can manifest as follow-up, things like that, things that are, important for health outcomes. And just to, might be useful for someone in their work, but when we think about stereotype threat, this is the unpleasant psychological experience of confronting negative stereotypes about one's race and ethnicity, gender, sexual orientation, or social status. And it can impair and interfere with really poor performance, can manifest as poor test taking performance. And, for example, giving a math test to female women participants and saying to the women, man, these women don't really know how to do math. And it really can manifest like, high levels of stress. So performance and health can be impacted by that. So, what can we do as researchers? We can't fix or dismantle the structures that exist that currently exist that, perpetuate these things. And some of us really can't just end segregation just with kind of a snap of our fingers, which would be wonderful and equalize the access to things. So, we can really think about our power, position, and place in research and on our teams, uh, and think about the questions we ask. Are they perpetuating racist tropes or attempting to use race as a biologic determination? And this goes in all aspects. Or what question are we asking? Are we asking a question about the genetic differences between people, a race-based question, or genetics-based question? Are we asking, and do we actually mean, does racism affect our patient's outcome in our study design? Are we attempting to have equitable inclusion and exclusion criteria for all our patients? Are we thinking about really overcoming the language barrier? A lot of us, and I just did this with a study, a lot of us use this, they're just like, okay, we're not going to only English speaking patients. Why? Right. And particularly for exposures to injury, when a lot of our undocumented patients are limited English proficient and use our emergency services for injury specifically, I think we all need to, as injury researchers, need to think about mechanisms to kind of impact that when we design our studies. Again, our data collection tools, like, are we creating ones that are, readable for people who have poor medical literacy? And the current trope is to, by, just, I think all research is to create everything at a 6th grade level or below. And so using, document checkers, things like Hemingway, and I think there are a few others, to ensure that whatever study tool or collection that we're using, is it, accessible? When we're analyzing our data, how are we using race? Are we using it as a biologic determinant in our analysis or not, right? Again, we're being previous at all aspects. I think it's important for us to think about what does race mean here, and why are we using it, and how is it impacting what we're doing? Again, and I included that ESL. So, an approach that I think that we can use when we think about this in this backdrop of really distrust about our patients, from our patients, is, thinking about disempowerment and building trust with our patients and our community, our participants in our community, building empathy and understanding, ensuring involvement, our involvement, their involvement, and really doubling down on participant and patient engagement and their autonomy, and practicing community community-based participatory research or community engaged research. I think as injury researchers, it's really imperative of us to include our community in whatever we do, and getting their input. So even if we, as researchers, never join a protest or advocate for a policy change by going up on the Hill, again, the side of Snowtown. So always feel free to go up there and advocate for all the things anti-racist, right? Studying, acknowledging issues of race and racism can really make a difference in the day-to-day lives of not only our patients, participants, and our colleagues. And we can do this by increasing, how much we value health equity, by emphasizing that in everything that we do. Whenever we think about doing things that think about anti-racism or health equity, providing equitable resources and research to folks, ensuring that that's front loaded, right? It's not something that we just kind of tack on at the end of something else, or it's like off cycle or whatever it is. Mobilizing our diverse team, kind of maximizing our network, ensuring that as much as we can, whatever we do reflects the change that we're trying to bring, right? And supporting and empowering both ourselves and our colleagues. So I think knowledge is the first step, and I think that's where we are. And, when we think about mitigating our own biases, Hannah loves this charge squared mnemonic, just to think about the change, your context. So is there another perspective that's possible if I'm being challenged by something I've said or done? Is there another perspective that I could? One of my really dear friends, I like to use this anecdote, some of my favorite ones of my own instance of kind of race-based, or yes, this was actually race-based bias, so language, both race and language-based bias. It was in our critical care area. It's not a research, but a clinical one. It was in our critical care area, and signing out to another attending. This is like when I'm, and I was just like, that patient in bed 6, like, I don't really know what's going on. It's just like, he was in a crash and like everything hurts. I don't know. And she's like, she's like one of those. And my colleague asked, like, what do you mean by that? And I had to reflect myself. What did I mean by that? And I meant something terribly racist. So, and be honest with yourself, acknowledge and be aware, and avoid blaming yourself. And I blame myself because I should know better. I know that we can do something about it. And, I've never actually used that kind of charged language since then, because that was like a really important moment for me. So, and realize when you need to slow down. Again, we're signing out. There was like a code coming or something. We were trying to rush. And I can't say that if it was in a slower time, I would have done something differently. But again, just taking a step back and get to know people that we perceive as different than us, right? And engaging and remembering that we're doing this work because we really care about humans, and we want to advance not just injury research, but equitable injury research, and empowering our patients and peers, right? And pairs. So in conclusion, we know that the US struggles with a legacy of racism, and all levels of racism can affect health and access to opportunities, and also affects our participants for research, right? Their patients don't want to be experimented on. They don't want to be a part of our research because they feel like we might be hurting them. And so addressing the effects of racism and bias in health can help us to be better colleagues, providers, researchers, friends, all of the above. And with that lovely noise going off just in time, I'm just going to open us up for discussion, and please stay tuned for the rest of our series. I'm happy to take any questions right now. I think it
Great. Thank you so much, Dr. Wilson. What a really important topic, and great talk. Anyone can ask questions either in the chat, or if you just unmute your microphone, and if you can, turn your video on if you're going to ask a question. So we'll just wait a moment there.
Oh, sorry. It's so funny. I thought this was a webinar, or else I took all my like audience questions out, and as I'm going through, I was like, oh, you should have just
well,
asked them.
Yeah. And Francesca Bowden said, "Thank you, Taneisha. Excellent job and great take on message."
Thank you so much.
And others are saying thank you as well. I'll pose a question. So, I'm submitting a grant next week, and to the NIH, and we have to identify as best we can to project the race and ethnicity of the subjects that we're going to recruit for the study. And this is a concussion study looking at concussion care in the state of Rhode Island. And what's interesting is my subjects are actually the healthcare providers. And what struck me is that, well, first of all, I had to take my best guess at race and ethnicity of healthcare providers, which in various emergency medicine or emergency department and primary care settings, which made me very uncomfortable because I didn't, I know that someone's perception of race or ethnicity is not accurate, but I also know, just from doing multi-center work like with PCARN, that a lot of the race and ethnicity categories of patients are either self-described or rather, self-identified based on reported by the patients, or sometimes it's by the person doing the registration. Yeah, the registrar. So I was wondering if you could speak a little bit to that, and sort of like what you would do to improve that aspect of care, or let's focus on research, that aspect of research, especially as applies to injury-related research.
Well, I think that, race matters because of racism. And so I think self-reported is as best as we can do. But like you just said, it's like, someone might actually say, well, my great grandma was like actually Italian, and then my mom and my aunt, my mom is like her dad was like black and blah blah blah, and like what I identify as black. What does that mean to us? Like what does that mean? I think the reason why we do use self-report though, and I think that's why that's important. I think it's how the patient kind of exists in our world, in our very race conscious world. And I think that continuing with that practice is important. Now, when we create the categories that the patients can fill out, I think that's where we sometimes like run into trouble, or have questions for ourselves, because having the patient report, I'm both Irish, Mexican, Native American, and Black would be crucial. But when we give them that form, actually, we give them the 6 things that the U.S. Census Bureau uses, and I actually do advocate for using what the Census Bureau uses, because I think it is a reflection of what's going on in our society. And I think as crude of a tool as that is, I think it's still important in our current context, because that's how resources are allocated and are assigned. And I think continuing to use that is important. But yes, having the patient self-report, because I don't know if I think it would just be, you'd probably think I was losing my mind if I walked around, it's like I'm white, like identified as white, but like if that's what I say, that's what I say. That's what you have to report. And I think we do have to use whatever the patient says. I do think self-report is important. When using databases, it's our limitation. It's whoever had put that in Epic, like, is it the registration? Did the patient actually tell them that? That is a limitation, and it will continue to be a limitation. But, what I do know is that using the data we have, we know that there's disparities, right? And so tracking based on what we've used, I think, is really important. I think that will give us the best indication of whatever we're doing, whatever we're trying to implement. Is it working? Is continue to use the old thing, which I know we need to get away from, but it is what we have. And so stay tuned for next time. We'll talk about all these great articles and work that could be improved on that use race as categories, and how folks use that in ways that are problematic and ways that are not so problematic. But stay tuned.
Yeah, that would be great, because as I was trying to do an analysis recently, we were looking at children presenting to the emergency department in primary care settings, and we saw that there are some that were reporting multiple races, or patient reported. And then in my mind, it's, oh man, so what do I do for the statistical analyses, right? Because a lot of times you want to you want the categories of race and ethnicity to reflect what the population is, but sometimes you'll have very small samples of some combination of race and or ethnicity. So really looking forward to that further discussion, because I would love to.
Yes, we'll talk about parsing, marginalized identities, and, figuring out, is that what, based on our question, which should be about racism, not so much about race, based on our question, how do we use that? But yes, stay tuned. You see, because I'm an emergency physician, that's my primary training. But nuanced discussion about genetics and all that is not what we're going to do, but we will talk about just the state of the evidence.
That's great. Does anyone else have any other comments or questions for Dr. Wilson?
I don't see anything in the chat.
Lots of kudos in the chat. People are very appreciative. All right. Well, thank you again, Dr. Wilson. This was a really wonderful and important talk. We are going to be posting this on our COBRA website, and we look forward to your future talks on the topic. And for a full listing, you can go to the COBRA website. Julie, I don't know if you can put that in the chat, or I can probably find it as well.
Sure, I can do it in 1 sec.
Okay. And thank you again. And we hope that you all can join us for future sessions in these seminars. again, we have a full listing. We also have a symposium coming up on March 16th. And the announcement just went out for that. The full listing is on the Coburg website. A really great lineup. And if anyone has any comments, questions, or suggestions for future seminars, just let us know.
Thank you.
And there's the website. Thank you again, Dr. Wilson. Take care, everyone. Have a great day.
Thank you. Have a good one.